Beams, y'all. I'm Andrew Defy, aka the Gorilla Poet Laureate, aka the Hoodie God, aka Spitting Quarantino, aka I wear my sunglasses at night indoors because my eyes are as sensitive as my heart is, y'all. And welcome to the internet's favorite community health live stream, Masked Up. And although a few weeks ago we were thinking we might have to change the name, it looks like it's here to stay for a while. Shout out to the Delta variant, and we have a lot to talk about tonight. We are going to start off with the weekly Rona update regarding our kids going back to school as this variant is running wild. We're going to talk about some groundbreaking new developments in brain-computer interfaces. We're going to discuss the racist history of Medicare and Medicaid. Bet you didn't know about that. And we are going to break down some new science of how the wildfires in California are exacerbating the effects of COVID-19. All that. And we've got superstar lawyer Sadena Thevarajah joining us to talk about her work with HealthBegins, a consulting and training firm that creates upstream solutions to health disparities. And you know how much we love upstream medicine on this show. So go ahead, click that share button. The show starts now. So the biggest question facing the country as the Delta variant runs wild right now may center around children returning to school. The number of children hospitalized with COVID-19 in the U.S. hit a record high of just over 1,900 this weekend as hospitals across the South were stretched to capacity fighting outbreaks caused by the highly transmissible Delta variant. Vaccination is still unavailable for children under 12, so our kids are left at risk of contracting COVID. Yet the last year of online learning has been shown to have dramatically negative effects on our youth. With parents and community eager to get children back into in-person learning formats, a Delta variant that is just getting started, and others waiting in the wings, how are we feeling about sending our kids back into classrooms? Let us know how you feel in the comments, and here's our friends at Reuters with more.
The number of children hospitalized with COVID-19 in the United States hit a record high on Saturday, as hospitals across the South were stretched to capacity, fighting outbreaks caused by the highly transmissible Delta variant. The variant, which is rapidly spreading among the unvaccinated portion of the U.S. population, has caused hospitalizations to spike in recent weeks, driving up the number of pediatric hospitalizations to over 1,900 on Saturday, according to data from the U.S. Department of Health and Human Services. Children currently make up 2.4% of the nation's COVID-19 hospitalizations. Kids under 12 are not eligible to receive the vaccine, leaving them more vulnerable to infection from the new highly transmissible variant than they were earlier in the pandemic. The spike in overall cases has ramped up tension between conservative state leaders and local districts over whether children should be required to wear masks in school as they head back to the classroom this month. School districts in Florida, Texas, and Arizona have mandated that masks be worn in schools, defying orders from their Republican state governors that ban districts from imposing such rules. The administration of Florida Governor Ron DeSantis has threatened to withhold funding from districts that impose mask requirements, and the Dallas Morning News reported on Friday that Texas Governor Greg Abbott is appealing to the state Supreme Court to overturn Dallas County's mask mandate. The U.S. now has an average of about 129,000 new COVID-19 cases per day, a rate that has doubled in a little over 2 weeks, according to a Reuters tally. The number of hospitalized COVID-19 patients is at a 6-month high.
From Science Daily and Brown University, brain-computer interfaces are emerging assistive devices that may one day help people with brain or spinal injuries to move or communicate. BCI systems depend on implantable sensors that record electrical signals in the brain and use those signals to drive external devices like computers or robotic prosthetics. Most current BCI systems use 1 or 2 sensors to sample up to a few hundred neurons, but neuroscientists are interested in systems that are able to gather data from much larger groups of brain cells. Now, a team of researchers has taken a key step toward a new concept for a future BCI system, one that employs a coordinated network of independent wireless microscale neural sensors, each about the size of a grain of salt, to record and stimulate brain activity. The sensors, dubbed neurograins, independently record the electrical pulses made by firing neurons and send the signals wirelessly to a central hub which coordinates and processes the signals. In a study published on August 12th in Nature Electronics, the research team demonstrated the use of nearly 50 such autonomous neurograins to record neural activity in a rodent. The results, the researchers say, are a step toward a system that could one day enable the recording of brain signals in unprecedented detail, leading to new insights into how the brain works and new therapies for people with brain or spinal injuries. One of the big challenges in the field of brain-computer interfaces is engineering ways of probing as many points in the brain as possible, said Arto Normiko, a professor in Brown School of Engineering and the study's senior author. Up to now, most BCIs have been monolithic devices, a bit like little beds of needles. Our team's idea was to break up that monolith into tiny sensors that could be distributed across the cerebral cortex. That's what we've been able to demonstrate here. The goal of this new study was to demonstrate that the system could record neural signals from a living brain, in this case, the brain of a rodent. The team placed 48 neurograins on the animal's cerebral cortex, the outer layer of the brain, and successfully recorded characteristic neural signals associated with spontaneous brain activity. The team also tested the device's ability to stimulate the brain as well as record from it. Stimulation is done with tiny electrical pulses that can activate neural activity. The stimulation is driven by the same hub that coordinates neural recordings and could one day restore brain function lost to illness or injury, researchers hope. The size of the animal's brain limited the team to 48 neurograins for this study, but the data suggests that the current configuration of the system could support up to 770. Ultimately, the team envisioned scaling up to many thousands of neurograins, which would provide a currently unattainable picture of brain activity. So originally, Esha sent over an article on how COVID has exposed racial disparities, and while I was watching and doing some research of my own, I came across a medical history that I never knew about, and I don't think a lot of you know about either. We all know about Medicare, but how much do you know about the history of it? Did you know how racist the roots of Medicare are? I didn't, and it put a lot of things in perspective for me. Here's hoping it puts some in perspective for you. Shout out to the homies at Healthcare Now for this.
Among high-income countries, universal health care is standard, except here in the United States. Why is that? Here's a reason that you may have never heard before. Our failure to pass a national health plan is largely due to America's history of structural racism. In 1945, Democrats were in control of the House, Senate, and the executive, and President Harry Truman decided to push for national health care. That year, 64% of Americans supported a national health insurance plan. Support in the states' rights South, which was heavily Democratic at the time, was even higher than the national average. Seem too good to be true? That's because Truman's proposal would have expanded health coverage through Social Security, which at the time explicitly excluded agricultural and domestic workers. That meant 60% of Black men and 80% of Black women were not eligible for the benefit. However, the push for national health care coincided at a time when challenges to Jim Crow and discriminatory provisions in federal programs like Social Security were also underway. In 1946, Truman established a Civil Rights Committee, which desegregated the military and banned discriminatory hiring practices in the federal government. Southern elites began to link new proposals coming out of Washington with threats to segregation in education, healthcare, and housing. The possibility that a national health plan would desegregate the healthcare system and institute a significant transfer of wealth from whites to blacks caused Southern support to plummet from 66% in 1945 to only 22% 4 years later. Southern elites were a core constituent of the Democratic Party at the time, and nothing could be passed without them. In 1949, Around the time every other wealthy country was moving towards universal health care, the Democratic coalition fractured and Truman's plan in Congress died. In 1964, the NAACP won a landmark Supreme Court case requiring hospitals built with federal funds, which was most of them, to desegregate. A few months later, the Civil Rights Act was passed, reinforcing this mandate. Passage of a true national health plan was still blocked by Southern Democrats in the 60s, since after the Civil Rights Act, this would have meant desegregating the entire healthcare system. So in 1965, the Southern delegation finally came to the table to negotiate the creation of two groundbreaking, yet limited healthcare programs: Medicare, which initially covered only seniors, and Medicaid, a state-run program for certain groups of low-income people. The Dixiecrats ensured that these programs were designed as much as possible around the racial hierarchies in the healthcare system. For example, Medicare is split into two parts. Part A, the part that covers hospital care, requires no premium. Medicare Part B, the part that covers physician care outside of a hospital, does require a premium. Why split Medicare into two parts? Part B was designed this way so that physicians' offices in the South could claim that it was a voluntary insurance program, not a direct government payment, and continued to racially segregate their offices and refuse Black patients. And why was Medicaid created as a federally funded but state-administered plan, while Medicare was administered by the federal government? This compromise allowed Southern states to discriminate against low-income people of color in terms of eligibility as well as benefit levels, and this also dramatically slowed the desegregation of nursing homes. While Jim Crow laws no longer exist, the impact of structural racism on our country's healthcare system has been profound. People of color are still overrepresented in states that have poor safety nets and strict Medicaid eligibility requirements, and new waves of immigrants, particularly Latinx, have fallen into these systems of racial inequity created for African Americans. True national health care, like Medicare for All, was blocked by segregationists during the post-war period when the rest of the developed world was establishing healthcare as a right. By the 1970s and 80s, a large healthcare industry and lobby had emerged, making passage of national healthcare more difficult and likely requiring a massive social movement.
So I had my first COVID scare this past week. And those of you who've been following along know that I have a special edition immune system and that I am very careful with who I interact with and where I go. I keep spray sanitizer in my handbag just in case anyone stands too close to me. You know what I'm saying? But the pandemic doesn't discriminate. Anyway, besides being exposed, part of the issue that made me think I may be infected was my breathing. I spent the week trying to decipher whether I had COVID or whether it was the smoke in the air affecting my lungs. While my test came back negative for COVID, it turns out that the California wildfires and COVID are working together in deadly combination. Here's News Time with more.
Pollutants in smoke billowing from huge wildfires in the west of America have probably caused an increase in COVID-19 infections and deaths across several U.S. states, new research has found. Last year, more than 10 acres of land were torched by wildfires, with 5 out of the 6 largest fires ever documented in California occurring within just a few months. The burning trees, shrubs, and buildings gave off enormous plumes of smoke containing small particles of soot. The spread of these tiny particles, known as PM 2.5, probably caused a spike in COVID cases and deaths in parts of the U.S. West, the new paper has discovered. The smoke helped raise the coronavirus infection rate by nearly 20% in certain counties, with half of all COVID deaths in some places attributable to the pollution, according to the study. In some counties, the association was very strong indeed. On days with lots of wildfire smoke, the COVID cases went up by a lot, said Francesca Dominici, a professor at the Harvard T.H. Chan School of Public Health who co-authored the research, which was led by Xiaodan Zhou, a researcher at Esri. Combining wildfires with this pandemic can have a really disastrous effect. It's disturbing. Previous research, which Dominici was also involved in, found that a small rise in people's long-term exposure to air pollution is associated with an 11% increase in deaths from COVID. Another study from last year suggests that 15% of all COVID-19 deaths around the world are attributable to dirty air. Researchers have said more work needs to be done to fully establish the connections, but there was now compelling evidence that polluted air is exacerbating outbreaks of the coronavirus. It is thought that emitted pollutants can help spread the infection, while also weakening people's lungs before they are infected with COVID, raising the likelihood they will get severely ill or die. The latest paper, published in Science Advances, analyzed 92 counties across California, Washington and Oregon and sought to eliminate causes of COVID increases other than nearby wildfires. It found that the wildfires had the largest impact upon COVID cases in the counties of Butte, California, and Whitman, Washington. The greatest influence on COVID deaths, meanwhile, was found in Butte County and Calaveras County, California. Last year's spate of wildfires may well be surpassed in 2021, with huge blazes underway such as the Bootleg Fire in Oregon, which at one point was the size of Los Angeles, and the Dixie Fire in Northern California, which is the largest in the state's recorded history. The town of Greenville, California, was almost completely destroyed by fire last week. Smoke from the fires has been detected from space, sweeping as far east as New York, where it turned the skies hazy. On Saturday, the city of Denver experienced the worst air quality in the world for several hours due to smoke from western wildfires.
Our guest tonight holds a law degree from Washington University School of Law and a public health degree from the Johns Hopkins University. She was part of the Obama administration at the Office of Health and Human Services Secretary during the passage of the Affordable Care Act. She is also the managing director at HealthBegins, a unique consulting and training firm that creates upstream solutions to health disparities. And you know we love our upstream medicine on this here live stream. We are so excited to have her here. Y'all, welcome Sadena Thevarajah to the show. Ms. Thevarajah, you are here with us tonight. Thank you for being here. First and foremost, how are you doing?
I am doing great. Thank you so much for having me today.
Oh, so excited for this interview. So as managing director of HealthBegins, which is a consulting and training firm that creates upstream solutions to health disparities, you have extensive experience promoting health equity, but you're also a lawyer by training. Can you talk to us about what motivated you to pursue a legal degree despite your interest in public health?
Yeah, that's a great phrasing of the question because I actually pursued my legal degree because of my interest in public health. I always knew I wanted to be in the public health world. I'm an immigrant. We left our home country because of essentially political determinants of health. We were refugees and we came over here, and it was always the underlying focus for me to pursue better health outcomes and to kind of recognize that there was like legal structures involved in it. When I first started doing my community-based work, I started getting the question of why are my communities feeling strapped in this way? Why are there these outcomes in certain clusters? Why are asthma rates turning out this way? Why are people afraid to go to the hospital and what they'll hear and what they'll have to pay? And kind of like peeling back those layers of the onion, it always comes down to, well, because we're a nation founded on laws that are not great, right? They're based in white supremacy, they're based in racism, and it's really a structural issue. And so it was public health that really led me to peeling the onion in that way, and then recognizing that I was really green in that regard in the legal field. So I wasn't raised with a lot of lawyers around me, and I decided to go to law school to kind of get rid of that greenness, to better understand what were those structures. So that's how I landed there.
And thank you from all of us for peeling that onion. It's quite the onion sometimes. So how has your background as a lawyer helped your work in advancing health equity? And what role can attorneys in general play in reducing health disparities?
Yeah, this is a great question because I think something that I often asked myself when I was trying to figure out my role was, what's the role where I could have the most impact, right? Like that was always part of my journey. And it was really more recently that I realized that's kind of the wrong question, isn't it? Because the flip side lets people cede responsibility. It means there are some roles that don't have impact. And the real question is really, how can I make the most impact from where I am? And, that's a journey that I walk every day with our clients and partners. And really, as an attorney, I think every attorney has a role here. So there's so many roles. There's soft skills of creativity, advocacy, curiosity that are really, part of legal education, and they kind of get hammered out in some kind of environments. But I think that you always can dig deep into those to think about how you can take your position and not use it as a barrier, which a lot of people view attorneys as within organizations. They're like, oh, I need to send it to counsel's office. And the subcontext there, right, is like, they're going to say no. And that's because we've kind of like let attorneys fall into that stereotype of being risk averse, of not being creative to find solutions. And I think that what is needed, especially in this moment, is to think about, well, what can we do to enable better relationships with community partners? What can we do to enable and empower people who should be having a seat at the table? And I think attorneys, especially in organizations, have a role there. Of course, there's also hard skills, right? And HealthBegins is a proud partner of a recently announced partnership between Kaiser Permanente and the National Center for Medical Legal Partnerships. Medical legal partnerships are huge. These are legal aid attorneys who take on cases to help with eviction, to help with utility bills that are getting cut off, to help people apply for disability. So there are all these hard skills as well in terms of actually taking on cases that can really play great dividends in reducing health disparities.
Such an enlightening answer. So you recently co-authored a health equity guide that outlines how the use of, quote, light and heat can drastically transform healthcare systems. Can you explain what light and heat are in the context of this guide and how they can be used to promote health equity?
Yeah, I think we started using light and heat as a shorthand while we were drafting it, and it stuck. So really, through 2020, right, we all witnessed the movement that was building, not just because of COVID and all of the effects of COVID, but also the uprisings that were taking place. And we saw that healthcare leaders were now kind of had more of an appetite to place health equity at the forefront of their organization's work. Many of them have been doing this work, but really there was this political movement that was bolstering the confidence of organizations and champions within the organizations to really center health equity and to do it meaningfully, more than just talk. And so we got together as a group of folks from HealthBegins, JSI, Health Leads, Human Impact Partners, and Siren at UCSF. It was really inspired by Human Impact Partners Health Equity Guide, which was designed for local and state health departments. And we thought, is there something that we could create, a guide to meet the moment, to help these healthcare institutions think about how they can do this transformation work? And so that's where light came from in terms of bringing light and heat. And as we're doing that, we were like, well, they need this guidebook, and we're clearly hearing that, but we also need to have a way to hold these systems accountable. And so that's the heat part. So the guide kind of goes through both parts, like outlining how you can do this work, giving you a framework for it, and then also key questions and ways to think about accountability for stakeholders to hold the systems accountable for the work.
Absolutely. And where can we find that health equity guide?
Yeah, so one of our partners, Health Leads, is hosting the guide on their website. I'm happy to share a link so that you can share with all your viewers. And that's where it's being housed right now.
Beautiful. Yeah, we would love to. And then I'll say something like, it's right here. And we'll pop it up right there. So, just another small question for you. What changes should we be making on an individual or systemic level to address the health disparities we are seeing today? How do we fix all of it?
Luckily, you told me we have all the time in the world today. So. Part one. No, I think, it's such a hard question to answer because it needs to be nuanced. It, again, goes back to roles, right? And how we can make how we can make changes within the roles that we occupy on the individual level and within the communities that we're a part of and within the societies and systems that we're a part of. And so I think, something like the Light and Heat Guide can help do that. And I think the most important step for any set of changes is commitment. And commitment is a huge step. It's a meaningful step. It means recognition that you might have to cede privilege, you might have to cede territory, you might have to cede resources. And so that first step of commitment that's underlying any type of specific changes is huge. And that's really required for the health disparities. I think a lot about this piece by Arundhati Roy. I don't know if you're familiar with it, through the pandemic portal. She wrote it April 2020, kind of at the beginning of all of this. And she talks about how historically pandemics forced people to break with the past and imagine a new world. And, she's a brilliant writer, and so she does it really artfully, but she talks about how you can walk through it, dragging the carcasses of your prejudice and your hatred, your dead rivers, your dead ideas, and kind of all of that floral language, or you can walk through it lightly with little luggage, ready to imagine another world. And I think that's the biggest change, is for us to think we're not returning back to normal. We can't return to normal because normal got us here. And so we're committing to making a change. It's going to be profound. It's going to hurt. It's going to be difficult. And we're going to use whatever tools and friends and our people that we have at our side to make those changes.
Absolutely. And commitment, right? Like,
absolutely
perfect. So I got one last question, and it is the question that I ask everyone who comes on this show, because we like to hunt joy around here.
Love it.
Where are you finding your joy today?
Yeah, I love that question, and I feel like I should ask myself every night that, just to have like a good night's sleep, right? That's beautiful. I always find joy in my people. And so that means my family, that means all my communities that I occupy. So neighborhood, friends who are like family, people who share my lived experience, my ethnic background. So always my people is where I find my joy.
Absolutely. And you just made a new people today.
Yeah, I'm so glad.
Now. Thank you so much, Ms. Thevarajah, for talking to us about the light and the heat, and all the light and the heat that you help bring into this world on an everyday basis. We appreciate you.
Thank you so much for having me. It was great to meet you.
And that is another episode down of Masked Up, the internet's favorite community live stream. We really appreciate y'all tuning in every week. We couldn't do it without you. As always, thank you to our guest and the rest of the team at Masked Up that make this happen. We'll be back in a couple weeks. You already know, like we always do at this time, health doesn't come from a pharmacy, y'all. Till the next episode.